Hi, everyone, and thank you for tuning into episode 9 of the Real Heroes Don't Wear Capes podcast. I'm Stephanie Carter here with Crystal Sutherland and Michael Weens from the HS Heroes team. And today we're joined by special guest, Dr. Ralph George. Dr. George, if you could please introduce yourself.
Hi, thank you so much for including me, and it's lovely to see you all. I've missed seeing people during COVID. So I'm Ralph George. I'm a general surgeon and a surgical oncologist. I'm an associate professor at the University of Toronto, and I'm the medical director of the CIBC Breast Center at St. Michael's. And I also have a very active HS practice. It's so much so that 2 days a week now are devoted entirely to HS with the population. And for other reasons, I've just checked, in my log of HS patients is now over 1,500.
Wow. So. That's incredible.
That's also a huge patient, load to carry. We're finding like one of the major burdens for physicians and patients is the lack of practitioners that treat or even know about HS. So that must put a heavy burden on the ones who do.
I think, and I think that's why the numbers are so high. It's because people are having trouble finding where to go, and unfortunately means a lot of people are traveling, and I don't want to sound trite, but I think in terms of the surgery of HS, the actual technical side isn't particularly complicated, and I don't mean that in a negative way. I think many people who are trained in surgical skills could look after HS if they could get to the point where they develop a comfort with it. And I think that's what's missing, because I think really, we even see people from out of province, as ridiculous as that sounds. It's happening, and you wonder how many hospitals and surgeons they've driven by to get here. We have to get.
Oh no, I was just gonna say I traveled 2 hours to see you myself.
Yeah.
We
got to get people more comfortable with it, recognizing it more, and yeah, then I think it would be easier for everybody: patients, physicians, nurses, everybody. So that's the goal.
That's something we've been really trying to move towards too, is get baseline HPCs to, even if you went into your GP and they could diagnose it, start you on an antibiotics, it would be able to triage the patients that are more severe to be able to see a specialist faster. But I mean, I went to the Skin Summit last weekend, and they said we only have 10 dermatologists in Edmonton, and I think 1 or 2 only treat HS. So it just shows, even in bigger cities like Toronto, you guys could have tens of thousands of patients for, the handful of you that there are there, if that.
The nice thing about being an HS physician is we all know each other, and somehow we all seem to get along. So it's really a nice community of people, but I think everyone wishes it was bigger.
Every time we talk to one of the HS specialists that we know and we bring up another person, they always kind of get very excited, and they're like, I know that person. And so we do see it quite a bit. Everybody kind of intertwined.
Yeah, I am going to visit Calgary in October to speak to the plastic and general surgeons there about techniques and things with Dr. Keeling, a dermatologist from Edmonton. So we're both going to Calgary. So, yeah. You know Dr. Keeling?
Yeah, he's been my derm for a decade. So he's done many surgeries on me. Him and his team are wonderful. They do the walk here in Edmonton with us every year. So
he's visited me twice now, and so I'm really excited to go visit him. I really like the man. He's larger than life.
That's a very accurate explanation of Dr. Keeling for sure.
I'm much smaller than life.
That's not true. I think on one of the previous podcasts, we explained your bedside manner as your like sunshine, because when you come into the room at the derm office, you make people very comfortable and you ease a lot of people's nerves very quickly. And we like as patients, we very, very much appreciate that.
You know, I think approach can be taught, eh? And I think that's something to teach. I'm a professor, and and my other job is surgical oncology. So, I've been taught in my oncologic training how to and I'm not sure if dermatologists are actually taught. So it's I mean, sometimes it looks like something is coming naturally, but often it's something's been taught and learned over time. And you're right, I do have a very practiced and methodical way about me, but it's been ingrained into me from the world of oncology. To simple things like to always make sure you sit. Try and be lower than the person you're speaking to. It somehow it makes them drawn in and pay more. There's all sorts of little things, and we've got to teach that as well as teaching how to sew. Surgeons.
I'm glad that skill translates, because so many HS patients are just in so much pain by the time that they're seeing you, that that little bit of extra kindness really goes a long way.
I had heard so many kind things about you, and all of them turned out to be true, sir. I felt very fortunate.
Thank you.
I mean, my local dermatologist almost speaks in soft whispers about the doctor. but I now understand why.
Yeah, I had a patient once make a slip of the tongue and called me Father George.
Do you take confession as you're cutting?
I wonder, Dr. George, do you remember the first time you saw HS?
I do, actually, which might sound odd, because I'm someone in their mid-60s and have been working for many decades, approaching 40 decades. But I do remember the very first HS patient, and it's telling that it did not occur in training. Didn't occur in residency. It occurred after I was in practice in Newfoundland as a surgical oncologist. The woman was sent to me because I do lots of melanoma and therefore operate in the inguinal region. And she had quite severe inguinal disease. That was slightly over 30 years ago. Our treatment is so much better now. And I operated on her many, many times. And never cured her. Never cured her. I think it did help, and she came back when she had recurrences and things. She was probably a early stage 2, and fortunately, never really went much beyond that, but would have gotten much better treatment today. Much better, and probably even better surgical treatment, and maybe not as much surgery as she got at that time. And since then, I've always had HS patients in my practice, but never as many as when medical treatment really improved, which was maybe, I'd say, 7 or 8 years ago. That made surgeries go better, because it wasn't just the surgery. And if you're operating on someone and their disease is under better medical control and ongoing, then the surgeries are going to do better. And I think that's what made surgery better. Better medicine made better surgery.
Like from biologics and like biosimilars?
And even just having clearer guidelines, the pathways, I think all of that helped. And of course, the biologics have been a big part of it. And I know they're not for everybody, but they've been a huge part of it. But I think just the advent of the biologics may have forced everything else to be a little bit more scientific about how it's being done. Things have been questioned more. And there is no cure, I know, and there's no magic. But at least it's more stepwise, more thought out. And I think that's been a big improvement too. Things like we never really had before, like the understanding of diet, the understanding of variation with menses. We weren't talking about that 10 or 15 years ago, and now it's really a part of it. Even understanding different subtypes or morphologies, like different people with different presentations may benefit from completely different modalities. So it's never exciting to have hidradenitis, but the changes that are happening are exciting. Yeah. They're not. There's some people who have such bad disease, and there's some people it's very hard to get them to respond. But most people now can be benefited. Most people, not cured, but benefited.
We do try to stress that within our group, that there may not be a cure, but there is hope for management and the ability to live a good quality life.
And especially when you're approaching surgery, you need to have realistic expectations. And I think it's very important that the surgeon understands what the patient is expecting. Maybe even more important than the other way around. And to do that, sometimes what needs to be removed isn't what the surgeon thinks needs to be removed. You have to really make sure you understand what's really troubling. Because a surgeon will never, ever cure HS. But a surgeon can focus on an area that's persistently troubling a person. Persistent. Like taking out a piece of bowel that's affected by Crohn's. That'll help someone, but they still have Crohn's.
I wonder, Dr. George, what is the recurrence rate for people who have had surgeries for HS in those specific areas?
So I actually, because I have an academic practice and I keep track of that. And part of the trouble when you're looking at it is people define recurrence differently. So I think if you define it as within a centimeter of where you operated, that the implication being whether or not, like, you need a strict definition if you're going to describe things. So that may be a little unfair to the surgeon, but I think it's reasonable. And if you
compare,
if you in a definition like that, it's somewhere between 18 and 25%, and probably gets higher the longer you follow someone. But the hope is the recurrence is never as bad as what was there to begin with. That even if you recur, it'll be less, and there'll be something easier to do about what's come back. So I think you always have to understand that it's not a cure. There's possibility of recurrence. There are people, remarkably, who seem to have real lasting effects from the area. And I think it also depends on where it is in the body. So if something is in the genitals, per se, that's a difficult area to operate on. It's difficult to get widely around it because you're limited by the skin available, by the importance of the area for other functions. And I think, the recurrence rates are lower in places like the axilla, where there isn't, where you're not limited by the urethra, where you're not limited by the need for stool to pass through. You're not limited by the importance of the genitalia. So that's a factor as well. It's a factor as well. And really, ongoing medical treatment reduces surgical recurrences. So a surgeon's best friend is a good dermatologist.
Just a personal story. I before I met you, before I think you had started working with Dr. Alavi, I had seen a plastic surgeon who did a de-roofing in my armpits, and they had closed after instead of leaving it open like many surgeons do. And when I got the stitches out, these tiny pinprick holes from the stitches opened, and then my whole, like both full armpits opened. But once those healed in, and it took a lot of time to heal in, but once they did, I never got HS in my axilla again. So I guess I've been one of the lucky ones who hasn't had recurrence after surgery, but I am also very, very well maintained medically, and I'm on like 3 different medications to help prevent flare-ups.
Yeah, and I think so. That's often a debate is whether it should be closed or left open. And I think we're increasingly seeing data. Even the SHARP study mandated that the areas be left open, and I think that made surgeons, not patients, but surgeons more comfortable leaving it open. And I think our own experience is that there's a lower recurrence and better long-term control if you leave it open. The problem, of course, is just people's lives or jobs or what they may make that difficult for them. It certainly takes longer to heal. It certainly takes longer to heal.
I don't know if you remember my surgery, sir. It was in April. And you closed me up.
Embarrass me.
No, I'm
kidding. Go ahead and embarrass me.
No. I just, the one thing that seemed to go a bit, not wrong for you, but I remember you saying that it was deeper than you had first anticipated. And I'm wondering, is that why you closed me as opposed to leaving it open?
I honestly don't recall, and I'm so embarrassed.
No, it's all, I'm sure I'm not the only groin you've seen since April. It's quite all right, sir.
I do often close a groin because I think people do find it easier to look after an open groin. It's just
I was very thankful that you closed it. I know I was expecting a lot worse than what it was. Like my aftercare was awesome. Like it went really well.
Well, that's good. But I mean, they're different areas, and it's not easy to have an open area in the groin. It's more sweaty. There's more germs in the area. It probably requires a real high level of wound care.
Okay.
But it does do well if you do leave it open.
There's no sign of recurrence there. Happy about that.
No guarantees. No guarantees.
I won't take you to court if something comes back.
When you're doing a surgery and say you're planning for a de-roofing, at what point does it kind of cross the line into wide excision, and can that be done in an office or should it be done in a hospital?
I think it's very variable. It depends on the disease. It also depends on the patient and the patient's motivation. And people are very, very different. There are some people who remarkably, and they're usually not big, tough guys, right? There are people who have remarkable pain tolerance, and they really can do more than I'm often surprised by how much people can tolerate. The hospital environment is, there's excellent anesthesia support. There's good lighting. It's a good spot to do a larger procedure. And if it's a procedure where you're anticipating that there might be bleeding, it's much easier to look after in a setting with excellent lighting, more help, and anesthesia where the patient is completely still. And if you're not worried about significant bleeding, to me, that's the real difference between if something must be done in the hospital setting. It's the concern about controlling hemorrhage, and that depends on depth and the breadth of and the amount of acute inflammation at the time. The best patient for a surgeon to operate on is someone whose acute inflammation is settled as much as possible. That can't always be done. Can't always achieve that. And I forgot what the question was. So the depth, to me, we're trying to get an article published right now on making the definitions more clear. And sometimes people use the word and they mean different things. And I think right now what I mean when I say de-roofing is we're taking the top off, but not cutting through the bottom part of a tunnel. So taking off the top, trying to remove all the biofilm and gel that's in that area, and then letting it regrow from that level. And that's less than excising the area. If you're excising the area, you must get to healthy fatty tissue underneath. But de-roofing is a wonderful thing. It can relieve pain and tension, and it often will provide good ongoing control of the area. Without
way more than an incision and drain, right?
Yes. Yeah. An incision and drain can get someone out of a real acute situation, but with a little more, not much more effort, you can probably do something better. If that makes sense. We tend to avoid INDs, but nothing is 100%.
I remember at SHSA 2019, I think it was Dr. Sayed who talked about how he doesn't do an incision, he does like a punch and takes a hole instead, and he found that it drained much better and healed much better. Is there any information to back that up? Have you guys tried it in your clinic at all?
Yeah, I actually do that a lot. I love the punch for that, and I often use it as the beginning of the de-roof. And then with the opening of the punch, it gives you a nice access for the scissors, and then you can follow the roof. And if you have a fairly large inflammatory nodule that's circular, that's a good way to start the de-roofing, and then usually work around it with scissors. I agree. I think that's an excellent way if you have a punch available, and any derm office has them available. So a good tool, a very good tool. I'm a fan.
I also wanted to ask who your most memorable patient was, because we know it's not Michael. Do you have a surgery that stands out in your mind that you remember from your time?
I do, and it's not a surgery. I think increasingly I'm understanding which patients can do well with some of the transcutaneous treatments, such as the fractional laser and even the radiofrequency. And I've had a young woman in her late teens with extensive breast disease, and with repeated concerted effort, it's been dramatically improved without making a cut. It's not been cured, but the difference is remarkable. But it's taken a lot of effort and investment and time on both her part and my part. And I think she's been a transition point to help me understand the role of some of these treatments that we're just learning about. So it's odd. It's not a surgery, but it's a spot that's very difficult for a surgery, underneath the breast and in between the breast. If you take too much tissue in between the breast, you kind of end up with one breast, which people really don't like. Okay? And
a uniboob.
Exactly. Yeah. So that's it, and but it may be because that's more recent as well. Certainly, there've been large operations, and people who've taken months to heal, and have had long-lasting results. I think I remember some of the difficult people, and HS is a horrible disease for someone who's otherwise well. But if you throw in some other things, such as mental illness or mental development, and add that to HS, those are some of the most challenging patients, because it's just difficult to communicate. It's difficult to sort of know what what's being understood and what isn't, and it's hard to maintain that relationship. I think there's some of my, in a way, so they're also some of my favorite patients, because I think the way to deal with them is multiple visits and to develop a trust and bond somehow over time. And that doesn't happen with a visit or even a couple visits if there's some of these other issues. So, like, imagine severe autism, HS, a difficult Down in HS, severe schizophrenia in the setting of HS. Those are very, very, very difficult.
What do you, I know you said multiple visits for challenging patients, but just in a general sense, how do you find is the best way to, gain a patient's trust and make them comfortable with a surgical intervention?
I'm not sure everyone would agree, but I'm very stepwise. I do one thing at a time, one intervention at a time, and I do like to see regularly, especially because those people may not remember me as well. I think the most important thing is it's hard to develop trust, and sometimes familiarity helps breed trust. Like nothing more than that, than just familiarity. To be someone they're familiar with and used to seeing, and I think that's the key to a breakthrough in this. Certainly, I think I'm sure we all have different patterns and tools, but for me, that's how I make it. It's tough, very tough on their caregivers, the parents or the caregivers. This is not becoming cheerful, you guys.
Is it hard? Like, are you the one that provides like medical or mental health access to those patients, or is that done through their GP? Like, is it hard for you to find resources to help those patients that way?
It is, and I find, I'm being very frank with you, I find that it can be a difficult population for their people trying to provide them mental care as well. And I think adding HS makes it even more difficult for the person providing the mental health assistance. And I honestly think I've burned some people out by sending them a lot of HS patients. And I try to be more careful to not overburden someone with a lot of HS patients. And I don't mean that in a negative way. Just the time commitment, the extra care. And if I'm a surgeon, so my role and job is actually probably easier because it's more concrete than what those sort of providers are trying to provide. And I think it may be even a deeper commitment on those providers than there is from someone. I've always, the surgeon always has the benefit of being able to stay superficial, to concentrate on the disease. And I suspect that's a much easier job than what we're asking some other people to do for people with mental illness. You know what? I think the most difficult job in medicine is to be a good psychiatrist.
For patients, when someone's going through a struggle and you can see this, do you offer the mental health support, or is that something patients specifically have to ask for?
No, we try and watch for it, and we try to screen for it, and we're not good at it. We're not good at it, and in my own practice, I know of 3 people that have been under my own care who've committed suicide.
I'm so sorry.
And I didn't recognize it in any of them. Not one. there's a clear deficit in my part as well. And I guess that sometimes people who are struggling often don't articulate, so it behooves us to ask, and even then, I guess it's not perfect. But certainly, I've missed it in at least 3 times that I know of, where people have taken. We need to do better than that.
I think that if someone is able to hide it from their loved ones who they're spending the most time with, then it would be very difficult for medical professionals to pick it up if they're that good at hiding it that people in their everyday lives are not seeing it. And I know that it's very, very difficult, and there's a sense of responsibility. But
So,
it's not solely on you or other people.
I know. It's still, yeah, exactly. But we do have to forward and be aware of it.
Mm-hmm.
It's interesting that inflammation looks like it's a risk factor for depression, like at a biological level, not at a suffering level. I mean, but actually at a chemical level. So there's probably a deeper link than just that the disease is difficult and horrible. There may actually be something chemical that's contributing to the amount of depression we're seeing in people with HS.
They had some data come out last Saturday at the Skin Summit, and they said that HS patients, like when they check for comorbidities, they really need to start checking for mental health. And they said there's a really high, I think 20% for suicide, and not only that, but self-sabotaging their lives. So
Yeah.
I think it's starting to come, hopefully, to a head a little bit more, and more physicians will start screening for that. The problem is there's, I know in Alberta, we've had so many cuts towards mental health and other social services and social support systems that can help patients. And it's hard because there's not a lot of services to help. And I thought, when I went to CADETH one year, that they said that mental health was built into public health in Canada as like a sub-in, and it was never really put out and had they never really put the effort and the energy into exploring it more. It was just an add-on.
I mean, this is a surgical talk, and look what we're talking about. That's just how important an issue it is, how ubiquitous it is. And clearly we need to be doing better. And if we do better, you know what? I bet surgery will go better. So it's integral to everything.
Let's move on to a bit of a lighter topic. Dr. George, you've been kind of part of the SHSA steering committee for a few years now. I was wondering if you could kind of tell us how that came to be, and how you guys decided that patients could be invited to this to learn more about HS.
I think in part it's because of the very strong patient advocacy groups that developed. My other hat is oncology, and in particular breast. And breast cancer is an area that's had a strong tradition of advocacy, and for the past 10 to 15 years, the major breast cancer meetings have made space for advocacy groups, advocacy representation, and for patients themselves to come to the meetings. So we've had that precedent from that community, and so I think that helped us be comfortable with it, and I've had an experience with it through breast cancer. So I think, they don't have much to do with each other, but they are both diseases with really good advocacy groups, and I think that's what allowed it to happen. And it does nothing but improve the meeting for the physicians. But I think people were nervous about it, but it certainly adds to it.
I remember one of the earlier years, it was being hosted at Women's College Hospital, I believe, in Toronto, and a patient had come, but then asked very, very specific personal questions about her son's case, and they kind of specified now that, like, patients, you cannot ask personal questions, but generalized questions are perfectly okay.
Like everyone else at the meeting, right? I think it's it may facilitate getting the proper physician that you need or something like that. But yeah, I think that that's clear. It's not meant to be a consultation in public.
Is there a speaker in the last few years that has really stood out to you during SHSA that you wouldn't mind talking about, or a presentation or upcoming tech that you were excited about?
I'm the co-chair of this year, so I don't want to be biased or anything. And I'll be chair of the next meeting as well. But my bias, you might be surprised, is the science. I just love the science, and I love to see how that's moving. And I wish we were doing more here. I'm very impressed by what our European colleagues are doing, and I think the best thing that I've seen as a surgeon is the culmination of finally a randomized prospective trial that included surgeons, and that was Sharps. And I know to your population, it may not have been a big breakthrough, but I think just in terms of drawing in surgeons, it was critical, and it actually improved surgery for HS, even though that wasn't the intent. It did. It did by mandating and making the operation strict, described, and controlled. So for me, there's my bias. It was my favorite presentations from Sharps, but my excitement is with the basic science, even though most of it I don't understand.
Or we understand none of it, and we still watch it.
None of it.
It's all hope, right?
Me personally, I like when they talk about studies they're doing, on diet, on lifestyle modifications, on things of that nature, because as a patient group, these are kind of things we can let the community know about. And, if they're not getting the clinical support, or they're struggling with only the clinical support, it makes them feel a little more like they can take control of their HS and have that control in their own hands just a little bit more than what they had before.
And I am so with you. I really, really believe in the diet data, and I encourage everyone. I remember when I was working with Alavi, if someone mentioned diet, she used to run out of the room and get me, the surgeon. Right? But I think it's so important. It's not an answer for everyone, and it's difficult. But you have to. I think it almost has to become your preference, and that doesn't happen overnight. It happens with time. It's like quitting smoking. It's not many people smoke anymore, but it's one of the hardest things to do. And culturally, it can be hard to change the diet you were brought up with that gives you comfort. Right? And it's important. It's really important.
Well, I think we're kind of at our time.
We didn't even talk about surgery.
We did. We talked about de-roofing and excision.
Yeah, I'm teasing. It's a complete package, and for surgery to go well, a good diet, not smoking, all these other things impact on what I do. It all needs to be looked after together.
Before we sign off, Crystal or Michael, do you have any other questions for Dr. George?
I might have one. I hope it's It should be relatively quick. I just occurred to me. I openly admit I use cannabis for pain. I'm just wondering if you had any thoughts for cannabis after surgery.
So I've even testified in court for patients using cannabis long before it became legal.
Yeah.
Narcotics aren't great. Yeah, I find it difficult to manage a severe hidradenitis without narcotics. And like in my cancer patients, there's a subset. It's not the elderly patient. I think the people who do best with cannabis are people who've used it before and know what and are familiar with it. But I think it's a really helpful adjunct. I worry about the smoke component because there are toxins in smoke that are bad for skin, and I wonder, for our cancer patients, I have it available as a tablet, Nabalone, which is the dose is clear and it eliminates that other thing. But
do you have the same thoughts on? Do you have the same thoughts about vaporization?
Honestly, I'm not sure because I don't know, but it sounds like it should be safer, doesn't it?
That's what I've been hoping because I do a lot of that.
Just eat a gummy, then you're not vaping or smoking anything.
My tolerance is too high. I've never really found an edible that will do much for me. I've tried.
I think what we need is a puffer, like an asthma patient does.
I dream that I could just set a dose that I know what I'm going to get in advance. It's the same standard dose that I know would help. But every time I get new stuff, you have to change. You have to figure out it's a trial period. Yeah, no, standardized dosing would be great. To dream.
Well, you got me way out of my expertise.
Sorry about that then, sir.
It's no problem.
Before we say goodbye, Dr. George, do you have any closing remarks for the HS community that may be listening?
I think that you people are doing a wonderful job, and you are making my job easier by what you do and the information that you bring. It's a devastating and tough disease. And we all need to work together.
Well said.
Thank you, everyone, for joining us today. And a very special thank you to Dr. Ralph George for the valuable information and the care you provide to HS patients. Join us next month for another episode of the HS Heroes podcast. And until then, remember, real heroes don't wear capes.